is Eric Mallack coming to us from Cornell, who will be speaking about modeling cerebral ALD lesion growth.
Good morning, everybody. My name is Eric Mallack. I am a pediatric neurologist from Cornell, and I'm also a postdoc with Dr. Eichler. So I live on the Amtrak train on the Northeast Corridor. Um, my research interest is in modeling early cerebral ALD evolution in the pre-symptomatic time period to try to understand what Dr. Eichler was alluding to this morning. Understanding cerebral ALD lesion growth in an era of newborn screening, and how can we understand that at a mathematical and biological level. And then I also see patients in New York City at Cornell, and I have a joint faculty appointment with MSK, and I can tell you a little bit about that at the end, but I am seeing patients. So no disclosures, but I am NIH funded through the NINDS K-12 program. So I'm going to talk to you a little bit about modeling, but also what is the context and what we as a group were charged to do in terms of coming up with standards of care for neuroimaging and cerebral ALD. And the questions we had to sort of answer are: when do you start, how often, when to administer contrast, and when you start imaging kids who were identified by newborn screening, how do we do this safely? So I'll talk a little bit about the clinical background of the disease. I don't have to tell you guys pretty much anything that you don't already know. And we'll talk a little bit about the practical issues around serial imaging, and that'll essentially show you that we need early predictors for disease progression. Talk a little bit about my current work, and then talk about standards of care and how we can use data to essentially inform what we're doing. So a little bit about the clinical background: childhood cerebral ALD. We know it occurs in 30 to 40% of patients with ALD. Highest incidence of the disease is between the ages of 3 and 12 years old. It's defined by the appearance of a T2 lesion on MRI, most often occurring in the splenium. And what will end up happening is about 10 to 20% of these patients will never contrast enhance. They'll undergo spontaneous arrest of disease. They are not eligible for things like allogeneic bone marrow transplant, or in our new era, gene therapy. This is versus the 80 to 90% who will generate some form of contrast enhancement. That is the marker for progressive disease, and these are the patients that are eligible for transplant. As it turns out, ALD and cerebral ALD is purely radiographic early on. And so there's some good news there. In the pre-symptomatic window, radiographic disease precedes neurologic symptoms. And if you can figure out who to transplant and you transplant them in the pre-symptomatic window, survivorship is excellent. And like I said, we live in the era of newborn screening and gene therapy. But like all things, so here's the rub. In the pre-symptomatic window, patients are already undergoing neurocognitive decline. And I'll show you a publication that came out recently that demonstrates that. Post-transplant survivorship decreases significantly after the onset of neurologic symptoms, as identified by the neurologic function score, which was introduced earlier this morning. We all know it's fatal without treatment. The LESS score is the gold standard, but it's not specific to group. It just tells you how much brain disease you have, but it doesn't tell you which group you're going to fall into. And then there's been this clinical observation that's floated through the literature from Dr. Moser initially, and then from Ali Fatimi in his work earlier on, early 2000s, that when patients undergo contrast enhancement, their disease speeds up. I thought that was an interesting clinical observation, and it became the basis for my hypothesis for some of my work. So this is just data showing that post-transplant survivorship, if you stratify by LESS score, if you have a LESS score less than 10, you do very well. You survive. LESS score greater than 10, not so well. But the real driver for survivorship is symptomatology. Like I said, if you can transplant patients in the asymptomatic time period, survivorship is excellent. Once you get one or essentially greater than one deficit in, as they say, the train has left the station. So we have to start thinking about, well, when do patients become symptomatic? And I think from a clinical perspective, that's really what clinicians are going to have to face. You have patients who are identified by newborn screen. You get a patient who gets their first lesion on MRI, and trying to understand, in the context of having to intervene and figure out whether you qualify for transplant or not, when do you become symptomatic? So this is work from Dr. Moser and his 350 plus patients. Is there a pointer on here? The top button. Oh, Nope. Back. Oh, cool. So what you'll notice is in higher incidence patients, age incidence, when you're between the ages of 3 and 7 and you have an MRI score less than 3, at least in his group, his patients weren't symptomatic. And then something happens. When you get to a less score greater than 3, all of a sudden there's a jump in the symptoms. But that doesn't give you timing. That just tells you, you're sort of monitoring and examining your patients over time. And as a clinician, I'd like to know really what's happening in the brain much earlier, because you're essentially sitting, it keeps you up at night. Let's just leave it at that. And then understanding cases before 2 years of age. There was one case reported at cerebral ALD at 1.7 years. Bella, thank you for the slide. And the next one, I think. Oh, no, I'll let you know. So this is work out of Minnesota that came out in JAMA last year, and it showed that patients who were transplanted really early, as it turns out, with a score less than 4, what you'll notice here are neurocognitive, here's a couple of neurocognitive measures. Patients ended up having, oh, did I break it? I didn't break it, okay. And what you'll notice is patients, even if they were transplanted early, with a score less than 4, a significant proportion of them had pretty severe neurocognitive deficits. So even in that pre-symptomatic window, if you're not showing any neurologic signs, patients are at risk of undergoing neurocognitive decline. So, and then the last thing we have to think about in sort of the clinical setting is by the time you diagnose a patient with progressive cerebral ALD, there is then time between the time of diagnosis and the time of treatment. So we have this saying in neurology, time is brain. So that's the clinical context, and we were charged with thinking also around about the practical issues around screening. So this was put out by the New York State Newborn Screening Group, making recommendations about how and when to start MRI screening. The recommendations were between 6 and 30 months, get an annual scan, and then between the ages of 3 and 10, scan every 6 months, 10 and 18, do an annual scan thereafter. The questions that we had to wrestle with is, when do you start contrast to identify those patients with progressive disease? The issue being that the FDA and the radiology world, they're concerned about the deposition of the gadolinium molecule in the brain and bodies, because you're repeatedly exposing them to contrast. You're potentially repeatedly exposing patients to contrast. And then what is the risk of repeated sedations? So this is the safety piece. How can we do this with some data, but also be safe about what we're doing? So this is a little bit just about the black box warning, but note that this is an update this past summer. The FDA identified no harmful effects due to brain retention of gadolinium, but they have to say that the brain will actually retain some. It's less in the macrocyclic molecules you'll see over on the right there, and most institutions have switched to the macrocyclics because your body retains them less. The only outcome that we should be really aware of is kids with pre-existing kidney disease. If you give them contrast, they're at risk for this thing called nephrogenic systemic fibrosis, which is pretty devastating. But kids without pre-existing kidney disease, there's been no known adverse outcomes. And then switching over, so this actually came out just this past summer, like 3-4 months ago. And the group out at Mayo looked at about 1,000 kids who had to undergo anesthesia or sedation, either singly or multiply, under the age of 3. And then they followed them for 8 to 10, 15 years, and they did IQ testing, and they said, what are your long-term neurocognitive outcomes if you fell into any one of these groups? And what they found is that there's no difference in IQ if you had one sedation versus repeated sedations under the age of 3. So that starts to get at whether or not anesthesia plays a long-term role. If you look at secondary outcomes, the patients who had multiple sedations, in the ended up having decrease in fine motor and processing speed, but that was a statistical difference. We, as Dr. Eichler pointed out early on, we see statistical differences, and we have to put them in the context of what we're doing clinically. Is it a clinically meaningful difference? And then if we know that kids who have cerebral lesions are at risk of undergoing neurocognitive decline, is this something that's going to be clinically relevant for us in that setting? And I think not. So the group put together consensus guidelines about when we should start scanning. And what you'll find in monitoring for cerebral ALD, we're trying to get as many data points in time of highest incidence. So right now the consensus is, and this is always up for debate and input, and we will integrate everyone's thoughts, is get the first MRI scan between the age of 12 and 18 months. We picked a window because I live in New York City, and if you tell a parent you need a scan at 12 months and 4 days and 68 seconds, they will schedule it at that time. So we want to, in the effort of not scaring people and trying to be cognizant of that and not scaring people away, as Dr. Dang said this morning, we were thinking about what are the how can we account for time? So get the first scan between 12 and 18 months, and then get the second scan a year thereafter. And then once you get to between the age of 3 and 12 years, which is the highest incidence of cerebral ALD, get a scan every 6 months. So what do we do about the contrast question? So if possible, if you are at a large multidisciplinary center, and so we have this luckily at Cornell, if you're in this scanner, I'll be there, and there'll be a radiologist there, and we will read your scan in real time. And if you do not have a lesion, we will not give you contrast in an attempt to limit your sedation time, and also not expose you to a medicine that you don't need, or a drug that you don't need to be exposed to. But then the issue is when you're not at a big multidisciplinary center, when you're out in the community and you're getting your scans, surveillance outside of a large center, if you're being sedated, the thought is, you know what, we might as well just do all the scans with contrast, because the risk is so high between the ages of 3 and 12. So the other piece of our working group was to think about expert review. So if you have a scan that you think might have a cerebral lesion, how do we have the people who are the world experts in this room have a look at your MRI and say yes, no, or maybe? So we started thinking about a centralized system for expert scan review, and maybe engaging a funding mechanism to support a central repository, such that a lot of the larger centers and people who have experience with cerebral ALD can access that and maybe give their 2 cents. And then there's a secondary gain to it, a research one, where you get a larger set for data analysis to help us really understand what early cerebral ALD evolution really looks like. And I'll show you why that's important in a second. So this moves me on to what the sort of the realm that I'm living in now. How do you predict progression of disease? And can we have more sensitive techniques that give us into the inside of biology of early cerebral ALD lesion evolution, way before they become symptomatic? So what you'll find is, ALD, everyone understands it as this disease where it fills out the white matter, but actually what you find is this is over 34 months, I put this together, that the disease actually spreads from the splenium, and as we know, backwards into what we call the parieto-occipital white matter, and then forwards. But actually the disease also, you have to remember, occurs in 3 dimensions, so it also grows upwards. And so that's usually not accounted for by our scoring system that exists today. And what you also know, and I'm not showing here, is that cerebral ALD, the way it spreads is it initially spreads along the white matter tracks, but once it gets into the back of the brain, there are all these crossing tracks that are going up and down, and it's spreading right through those as well. So you start to get insight into the mechanism of disease, because the disease spreads in parallel to the white matter tracks that Bella was talking about, but also orthogonal, which is a really fancy word for at 90 degrees in 3 dimensions. And it sort of gets at the mechanism. And so Dr. Mussolino will, her work really, I think, gets at this, this track agnostic disease spread. And so this was referenced earlier this morning, but what we're starting to find is that lesions in younger kids grow faster, and it's actually the older kids that tend to undergo halt of disease, and that's under review and hopefully will be out in publications soon. So the question is then, how do we go from these tiny lesions? I've highlighted them in blue. This is at one time point multiple slices. and then you can kind of stack these together and get a volume. How do you go from this tiny lesion, and what does the biology look like between here and between something like this? This is a patient with a less score of 11, and this is what cerebral ALD actually looks like. And our job is to never let it get there pretty much ever again. So this is the work that I've been doing. Each one of these curves, I'll orient you in a second, but each one of these curves is one patient. Each dot is an MRI, and what you'll find on the x-axis is time. The y-axis is volume, and it's the volume of the cerebral lesion. And I set time 0 to the time of your first abnormal scan. So this is what newborn screening really gets us. We can scan you, and you can have normal scans that tick along, and then all of a sudden, you get your first abnormal scan. So if I line all of these kids up, and so out here, these are all pre-treatment scans, and as you get farther away from your first abnormal scan, the risk of you undergoing contrast enhancement and the disease speeding up and symptomatology, all of that goes up. So how do we understand the behavior or the growth of cerebral lesions early on? So like I said, time 0, your first abnormal scan. So if I blow this up, what you'll find is that even though we use the less score, which is 1, 2, 3, 4, 5, 6, lesion growth in ALD is actually nonlinear. You can just kind of sort of see that from visual inspection. But you can imagine that there's actually a ground truth. There's this underlying curve that a lot of these cerebral lesions sort of follow. And so one of my backgrounds is in mathematics. So if you do some fancy mathematics and you do nonlinear regression, you can actually come up with an equation. So the equation that I came up with will effectively tell you what the relationship is between your volume and your perceived first time of, or what we think would be your first abnormal scan. And then you can do a couple of things if you know basic mathematics. I can tell you how fast your lesion is growing as a function of what the time was from your first abnormal scan and how fast you're accelerating. But we'll leave that. What's more clinically useful is that if you actually solve for the time, if someone were, one of the ways that we can analyze this is we get a scan and someone says, oh, maybe this is a less score of 1 or 2, but we really want to know how far in your disease actually are you. We can calculate the volume and then give you a time from when we thought there was the appearance of your first lesion. And why is that important? Because when you think about this boy up here, he's part of the model, but as an example, he had no preceding scan. So this is the kid that shows up in your clinic, has a CD, and goes, can you look at my MRI and tell me, am I going to be sick or not? What you find is all of these time points, the first abnormal scan, they all have a less score of 1. So this is getting at what Dr. Eichler was saying early, that early in the disease, the less score is not sensitive enough to tell you how bad your disease is. But this kid shows up, he has no preceding scans, he has a less score of 1, and you think, well, maybe he's early in disease, but when in fact, when you go out to the curve, he's probably actually a couple of months down the road. So this is helpful in starting to think about what this pre-symptomatic time window really looks like. So to go back to kind of the 30,000-foot view, Bella has put together and is starting to work on a systematic review, and we're starting to think about questions to ask the data that exists to date, all the publications. And one of them is, at least my question is, how long do we have? What does the pre-symptomatic / therapeutic window look like? What is the average time to enhancement? What is the average time to symptom onset? I think those are really important questions because it gives us the frame of time within which we should be intervening. So with that, I'd like to do a little shameless self-promotion because I was the only person seeing patients in the leukodystrophy clinic at Cornell, and I'm going from an I to a we. Dr. Bolens is the new chair of bone marrow transplant at MSKCC and has wonderful experience in metabolic disease. He came to us from the Netherlands, and he's been teaching me a lot since he's shown up. A lot of people to thank, and I thank you for your time.
Great, Eric. So I'm just going to challenge you on this one point about that can be confusing to families and parents, about that the early lesion growth is faster and it self-halts later. And I think it depends on how you're defining what faster is, right? So, because I think that you know, when you graphed it out, it was clear that there's a slow early growth. But if you're comparing, you know, the lesion size to itself as it grows, that percentage volume growth is large, right?
Yeah, so this becomes a math thing, and you know, in medicine, you do the best you can, and what I found going through the data is you essentially make small linear approximations to try to get an idea, but if you were to look, yeah, if you measure it versus itself, you get these percent incremental increases, and all we see that is the younger kids, those percent incremental increases are faster. The patients who are a little bit older that have cerebral disease, their percent incremental increase is just a little bit lower. So it kind of gives you sort of a risk stratification by age.
But part of the message is that your actually less score of 1 is probably retained much longer than we previously thought, right? So that there's actually this slow pre-contrast stage, and I think that's part of what's coming out through your work. So that's great. Questions?
Thanks. Say my name. Okay, Jeff Cleveland. I had a question. I think that the MRI is not sensitive enough to pick up how fast the disease is progressing in the early stage. And so I'm wondering if we can think about this in a different way, maybe use a different technique. So I think Florian has published a lot of work on this, and there's many other studies now that show that activated microglia are the predecessor to causing the neuronal damage. So can we maybe think about a study where we start looking at PET ligands for TSPO potentially earlier in these patients and see if that's a better predictor of when they're going to start accelerating the rate of which their MRI changes? Just an idea. So.
No, it's a great point. Probably there is a lot in the biology that can be tracked with imaging earlier than the T2 lesion that Eric is trying to understand in behavior. They're kids. A lot of the PET means radiation. So pretty much easy in research in the sense that you can get people to want to take the risk of radiating your kid in a systematic way, but it's not really feasible in the clinic. But there are tracers in MR that are being developed to track monocytes, microglia, to getting into the brain, and also blood-brain barrier disruption, which is something that I'll present later on.
Yeah, so Patty's work, and so this is the T2 work, but you know, thinking really hard about DTI as a really sensitive white matter. So maybe you know, a year or so from now, I'll have some information on the DTI work as well. But you know, not even waiting for the T2 lesion to show up, I think is really the goal.